You got it?
Yeah, great. Let me introduce you real fast. This is Dr. Ksiazek, who's coming to us from the University of Chicago, and she is in the ophthalmology department and is a neuro-ophthalmologist there. So she's going to be talking to us about those things, and I know a lot of you were asking about that ahead of time. Thanks.
And actually, I come from a background, I was a neurologist initially, then did a fellowship, and then did a second residency. So I'm actually both a neurologist and an ophthalmologist. Well, thanks, Dr. Watt, for the invitation, and thank you too as well. Oh, I'm sorry, I didn't turn this on. That's I didn't want their side conference. Is that better? No? Where do I put it? So it's on. It's on, so I don't have to worry. Okay. So we're going to break up the vision into input and output. And this is actually how I teach some of the medical students is we're going to first talk about things that go in and what you see and how CCMs can be affected by this. And then we'll talk about output, where you're moving your eyes and how CCM can affect that. So the input, we're going to discuss the sort of the anatomy of the optic pathway, the light going in. And what you find with input is that you get vision loss, where you don't see out of typically one eye, or you can't read. And the vision loss can be in the center, which is the fine reading vision. And also you can have vision loss off to the side, or your peripheral vision. So those two things can be affected as sort of the ingoing. And the output, where you're sort of want to look right, look left, you do that subconsciously. The center control is in the brainstem. Things start there and they go out from there. And it causes a lot of different changes. Some of it is double vision, or diplopia is what we say, and that's the more, we're going to go over a more specific example of that. But they're also more complicated, and I'm not going to go into great detail, but nystagmus, where the eyes jump and the world seems like it jumps. Or gaze, where you say, I just can't look right. My eyes, I have to turn my head and then I can look right. There are things like that that do occur, and it's not a double vision. So what goes in? Light comes into the eye, and then it bundles up in the back, and that cord is called the optic nerve, and the optic nerve is really the cord that connects the eyeball to the rest of the brain. And it goes right into the chiasm, where some of the fibers cross, and then they separate. And after the chiasm, there are two sides. The right side of the brain will take care of the left side of space, and the left side of the brain will take care of the right side of space. So it is sometimes confusing. Many patients, for whatever problem, will say, I don't see out of my right eye, but they cover their left eye, and it's clear that they don't see out of the right side of their left eye and the right side of their right eye. And without actually checking, you really may not be aware that it's not an eye problem, but beyond the chiasm, more into the brain. And all the processing is then done back here in the occipital cortex. That's your higher visual function. That's where you're interpreting what that light is bringing in. So when you have an eye exam, these are things that we check for the input. We check the vision and color as well. So how well you read, your color, your side vision, your pupils, and we actually look into your eyes. And there are other things, you know, a normal eye exam, you're going to get your eye pressure checked, but that doesn't really relate very much to CCMs. So visual acuity. So we always do it one eye at a time. You need to wear your glasses. If not, you may need to get a good, what's your best ability to see? So you may need to get behind this machine, a 4-opter, and get your best vision, and you use an eye chart, a distant one. Usually it's put up at the end of the room, projected. This is more of an old-fashioned, or a handheld if you're at the bedside. You're gonna use a handheld card. And again, one eye at a time. And if you look at the card, there are all these little numbers, very hard to read, 2400, 2200, 21. So this is what we record. What is your vision? And down here, that teeny little line is 2020. So the right eye, can it be 20/20? Can the left eye? And that's just, again, fine reading vision, your central vision. In addition to checking your reading vision, you want to know is the color, because sometimes you can see 20/20, but you know your vision's not normal. Something's not right. Your left eye and your right eye don't see colors the same way. You can even perceive that. And sometimes we'll pull out a book of color plates, and you can see a 15 and a 74, but we would check the right eye, reading each of these plates, and the left eye to see if the color vision is affected separately or in addition to the vision. We look at the pupils, and basically typically we'll put you in a dark room, illuminate from below, and see that your pupils look the same size. And then afterwards, we'll swing the flashlight from right to left. And as we swing, we see the pupils come down, and that's called a normal swinging flashlight test. So the eyes are, each eye is seeing the light equally in a simplistic fashion. When you have a problem with that optic nerve, and sometimes further on in the optic pathway, you may swing the flashlight and the right eye sees the light perfectly. Now the left eye was seeing 2400, had no color vision, and you put the light there and the pupil comes up. It's as if that eye is not perceiving the light as bright. And therefore, if you walk into a dark room, the pupil dilates. So the light is the same in both eyes, but this eye is not, the input is not the same. So the pupils help us with that as well. And this is an example of the CCM of the optic nerve. And you can have vision loss due to this. And it doesn't even have to be in the optic nerve. It can be next to the optic nerve. So it can be part of the brain and kind of just sitting on the optic nerve. And the compression alone can cause vision changes. One of the last parts we do in the exam is ophthalmoscopy, and that's when we look inside the eye. And you have to be dilated. It takes 4 to 6 hours. It's a pain because you're blurred for a while. But we use, this is a microscope on ratchets, a slit lamp, and this is an indirect. This is like a wide-angle camera. And we really look at the optic nerve, the retina, and the blood vessels, because we do know there can be some changes inside. So this is the optic nerve and the blood vessels, and this can be an angioma seen in the retina. So for a full exam, you would need a dilated exam as well. So now we're going to switch from the central vision to the side. And the side vision, again, we've got our optic pathway. If here, number 1 is the optic nerve, so one eye is out, just the right. Here's the chiasm. So the chiasm is where they have some crossing. And it has a very special side vision problem. It affects both sides of both eyes. So you have just a narrow center. So you have really, and it becomes very hard to navigate in space because you're very aware of this. Now, none of these are very simplistic drawings. Sometimes they're partial. They're not as severe or black or large. So just keep that in mind. This is for simplicity's sake. And then you go back out as they're dividing, and you notice on this right side of the brain with the lesions, all the field defects are now on the left side of the space. So when they go into the chiasm, everything switches. Right side of the brain, just like the motor function, left side for visual space as well. So you can get over here a complete, and this is what a hemianopia is, hemianopsia. You can get a quadranopsia, and this is, when you get back here, you can get this little scoop out. It's called macular sparing, which you can actually read in the center, but very close to it. You're aware that there's a darkness. And many patients, as I said, will come, they don't say they may not even say my right eye doesn't work or the right side of my vision doesn't work. They'll say, I can't read. And when you have a hemianopia, if you have it on the left, you can't find the next line when you're reading. And you may not be aware of why you can't read, but you can't. Or if you're reading along and you have a right hemianopia, you can't see the next word or the next, the phrase that you're reading forward. And there are little tricks like using a ruler in a book to help you with that. But these are things that you will see that patients come in complaining with. So we can check visual fields simply in the office by counting fingers. You put your, how many fingers, 1, 2, 5, you draw up 4 quadrants just in a simplistic way. And that gives you, and sometimes you will find things with that, there's no question. But often if they're more subtle, you need to do an automated, I don't know if any of you have had this, or known somebody that's had it. Most people hate taking it, but it gives really valuable information. It gives us a baseline, and then it allows us to follow as well. This is just a computerized side vision test, and this is what the printout looks at. This is probably normal. There's maybe a little lid effect there. But these are the Humphreys, and that's really the mainstay of checking side vision in an eye office. If you have trouble with a Humphrey just because of the speed, they can actually slow it down. You can ask the technician, please hit the slow down so I have enough time to push that button. But if you have trouble, you can always do a gold bond. There's a technician behind doing it, and this is what the printout looks like. And these are, they're going out to like 90 degrees, 60 degrees. This is your blind spot. These are different brightness of lights. So as the light gets brighter, the field gets larger. So we're going to look at a chiasmal lesion now. So that's that bitemporal hemianopia, temporal, nasal. And here is a chiasmal CCM, and here are the visual fields. Show that. If you get beyond the chiasm, again, in the right part of the brain, you'll get a left. If you see here, the gold bond is not a big circle. There's a little pie wedge in the inferior quadrant that's been chopped out. So somebody may say, I'm driving and I can't see the license plate. These are sometimes complaints that people will have, and they do a field and they're aware of that, but this lesion caused this deficit. So now we're going to switch gears. We're going to talk not so much about the input, but now we're going to talk about eye movement control. And really the command center is the brainstem. And there's three parts of the brainstem, but the two that are really where things initiate is the midbrain and the pons, and that is the pink and the purple here. So, and this is where things, there is certainly cognitive initiation, but you say you're going to do something, it goes down to the brainstem, but the brainstem is where everything gets put together. So in the room, you're going to just, doctor will have you follow a finger, follow a light. You're going to look up, down, right, left, in the four corners, and also straight. And this looks pretty good. But this person came in and said they were having double vision, and it was side to side. And double vision, we always term, is it one-eyed or two eyes? And if you have double vision, it typically, if it's neurologic, it's two eyes, meaning it goes away, I have it, it goes away, I have it. And that's really the one way you can check. It's called cross cover. People who have double vision like this, it's usually a cataract or something that's not unrelated to what we're talking about. So in this patient, he has a sixth nerve palsy, so he sees double vision side to side. So he's asked, is it one above the other? Is it an angle? Is it side to side? Do you see it straight ahead? Do you see it more in right gaze, left gaze? All those things help decide. And the exam, of course, what is this due to? So we're going to take a simple sixth nerve palsy. So you can see that this right eye is turned in, complaining of double vision. And he says, I have no double vision when I look to the left. It's gone. And it's worse when I look to the right. When he looks to that right eye doesn't move at all because the sixth nerve is not functioning, and the left eye moves normally to the right. So it gets worse to the right, normal to the left, and still double straight ahead. So if we see that somebody comes in and examine them, we do what's called a cover test. We go back and forth, and if you cover the straight eye, boom, that eye moves right out. It can move, but it's when they're both open together, they don't work. Think of it like a car's tires that are not aligned. It's out of alignment. And what are we going to first figure out what the alignment pattern should be, or what's causing it, and then how to remedy that. So we can use prisms to measure. And as you see, say this is these actually have numbers at 5 prism diopters or 10 prism. So as we increase it, the eyes look straight. These are triangular, they bend the light, and they allow the patient to see single. So this patient says, I see double, and here, well, it's single. So in the exam room, we actually put up these large prism bars, or prisms, loose prisms is what these are, and measure and get numbers of what. And we may measure you straight ahead, right gaze, left gaze, up gaze, tilt. Remember, the eyes are very complicated. Not only they look up and down, they also they have torsional movement. So we can do head tilts as well. And in doing all those measurements, we can say, well, this is a sixth, or this is a partial third, or this is a fourth, or a combination of them. It helps us figure out where the problem lies. And in measuring it, the other thing that's important to keep in mind is that you can only, because your eyes are so complex, you can correct it for straight ahead. So if I give you a 10 diopter here, 10 may not work over here. So you still see, you need a 20 over here and a 0 over here, just like that guy with the sixth nerve palsy. Not one size fits all gazes, okay? So here's the command center, and here's the nerves that are the 3 nerves, the 3rd, the 4th, and the 6th, control all 6 eye muscles. But there's all this other stuff in the pons and the brainstem. Like this. This can cause double vision that's vertical, but it's not due to a nerve. So it's more complicated. There are other centers that, this center here, the perimedium pontine, causes you to look to the side, both eyes, not one. So there's a lot of control in a crowded area in your brainstem as well. And this is an old book, but it just shows you how from the brainstem it goes out. And remember, these nerves are traveling through the brain, and as well as they're going from the midbrain or the pons and getting out to the eyeball, they may get CCM again to just sit on it and cause a little pressure. So it may not only be from the brainstem, it could be from other parts of the brain as that nerve is traveling through to get to the eye. And here you see the eye with the nerve, with the muscles. I don't know if that's well seen in back, it's probably too low, but there are 6 muscles. The 6th nerve does just 1 muscle, the 4th nerve does 1 muscle, and the 3rd nerve does the rest, all 4. And that's just how it is. It'd be nice if it was simpler. And this is, again, the cross sections. So you're taking the brainstem and you're cutting in the cross section and the nerves. And these are, again, control centers, but wiring up to your eyeball. So this is a section, this little dot right here is the 6th nerve nucleus. This is through the pons, and these little jagged lines are the fascicle, or the nerve actually coming out through the pons. So if you get a lesion here, you can easily get a 6th nerve palsy in the pons. And again, I'm staying with the 6th because it becomes totally complicated with everything else. And here, sure enough, you can have a CCM, and this patient had a left 6th nerve palsy. So it can be due to any cranial nerve of the 3, or a combination. It can be partial, complete, and it can be due to all these other gaze centers. And I didn't talk too much about nystagmus, but there are areas in the brain that can cause the eyes to jump as well. So what do you do? The first thing you do, most people will do it on their own. They patch. You know, if they close the eye, the double vision's gone. They can walk safely or grab something. And typically you cover the eye that's affected. Remember, though, that you have no depth perception or stereo. So if you're going to pour like your cream in your coffee cup, you may miss. You've lost that depth perception with one eye open. There are many things you can do with one eye. You can function pretty well just with a patch. This is not as cosmetically appealing, but it works. There are, you know, you can buy bandages and put them over. One of the ones I like if you wear glasses is I put a frosted tape over the eyeglass, and it usually is pretty cosmetically appealing, and it works very, very well. I actually like the Transport. It's a little bit more frosted than this. And you just trim it, and you can peel it off if you don't like it, but put it back on. And basically, you're patching. And that's what you can do, at least initially. Now we're back to the prisms again. We've measured with prisms, and the nice thing about prisms is you can use them to treat. And so you've got your measurement, and you say, okay, this person's familiar. But I don't know if you remember when she was in the news, everybody was taking pictures of her with her glasses. They were like, what's going on here? That's a Fresnel prism. You don't pronounce the S. And these are little prism bars, and it's a stick-on piece of plastic you put right in the glass, and you can order them. You can say, I want, you know, typically when I measure a 10 diopter, I'll say, I'm going to start with a 5. And if the 5 works, because your body actually takes care of the other 5. You don't always need as much as you measure. And start with a 5, and it's not enough, maybe you end up with a 6. But you put this in the glass, and again, the patient can see straight, single straight ahead, but remember that side up may not be. But our goal is 90% of your time is spent here and reading, and that's where we want you to see single. These are reasonably priced. They're $30 to $40. You can change them out as things change, when things improve, and they're not permanent to your glasses. You just peel them off when you're done. If you have a long-standing double vision, you can also grind it in. You can see that this is a triangle, so it's actually ground into the glass. This can be somewhat expensive to do. It may be more, it'll make the lens thick, but maybe you don't like those little lines. It's harder to change. I mean, you don't want to keep changing that, but you can grind the prism into your glasses as well. And finally, if you've been stable, and most surgeons won't, most eye muscle surgeons won't consider this, but you've got to have stable measurements. That's why you come back and do the prism measurements over and over again. For 6 months, we'll consider muscle surgery. And muscle surgery has its own reasons, you know, indications to do. Sometimes you won't do it if it's less than 10, because you can't suture a muscle less than 10. It's too hard to predict that. But something that's 10 or more, and basically there's 2 ways that we fix a muscle. It's very simplistic in a way. You can tighten it or weaken it. So if you think of that patient with a 6th nerve palsy, you know that the eye's not coming out. So you can take this muscle here and cut it. It's called resect. Cut that muscle and reattach it, and you've effectively shortened that muscle. And think of like a horse's bridle. You've pulled that eye straight. You can alternatively, there's preferences, and but you can recess it. You can take the muscle on the inside, lift it off, and move it back on the eyeball, and weaken it, and again, bring the eye out. It's important to remember that one of my professors actually said, I can fix your eyes in 1.2 surgeries. So some people, 20% of people, need more than 1 eye muscle surgery. And maybe even you may need to still wear prisms after that eye muscle surgery. And again, the same thing holds for the eye muscle surgery. It's not for the whole world. So when you're walking, driving, you're going to be doing, you'll adapt to it, but you learn to do a lot more head movement to keep things single in your vision. And this is my last photo. It's just, again, another picture. You cut the muscle, you measure, they're precise measurements, and you suture that muscle. That's a recession, pulling it back, weakening the muscle. Okay, I'm happy to take any questions. Yes?
My eye optometrist suggested we tried using a soft contact on this eye, so I had more vision, and it started off working really well, and then after a while, my good eye was like going up and down.
So you had nystagmus.
And it kind of got gray, and on my spatial, it's like, you know, like this was like, so I was like, I don't want to play this game. So I went back to patching.
Does your eyelid not close?
This one?
Yes.
No, it does not close.
Yeah, so that's, I didn't discuss that at all, but that's, so the 7th nerve that affects the facial muscles, if it doesn't close, it dries out, and you need to have a moisture chamber. And that's what you're doing there. You're creating a nice moisture chamber so the eye doesn't dry out. And the contact lens may have given you a new surface.
I was putting stuff in it up constantly.
Yes. Yeah.
So
Every 15 minutes.
yeah, like a job.
Right.
So why was the side telling me that?
I'm not sure. I don't know about the right eye. You said after you patched it, it went gray?
No, I started to use the contact and like, wow, I can see more. I had more vision.
Yes.
I'm like, what to do? And then this eye started going up and down. My vision wasn't as good. And my spatial was kind of off. And it was like this artist.
It depends where your lesions are. I mean, I could, you know, you have a CCM, it depends where it is in your brain that I would have to answer that question. I'm sorry, I can't tell. Oh, that's okay. Can anything be done to regain absent corneal reflex? No. In fact, you have to be vigilant about it. I shouldn't say no, never say no. Peripheral nerves can grow 1 millimeter a day or something like that. The trouble is sometimes they get lost and they don't find their way back home. And that's why some people have these, when they smile, their jaw goes up too much. It's sort of an overactivation. But typically, I've not seen a corneal one that grows back well. And you have to be vigilant. If your eye turns red, you get seen immediately because you can have an infection there and not know it because you don't feel pain like the normal person. So what you have to do is look in the mirror, make sure your eyes aren't red, keep them moist. I have a patient who has a problem like this due to another injury, but you have to be very vigilant about that. If you give it time, 6 months, if it hasn't come back in 6 months, I would say probably not. Do you ever recommend vision therapy for CCM patients with a success rate? It's controversial. That is there are some eye movement problems that are non-neurological. People who are born with eyes that drift out. They're not due to brain lesions. Those patients do well with vision therapy. And that's the only thing that's really has good hard data about that. What is being done to help treat severe glare? I have tried many different colored lenses, none have helped. Some of the orange ones work. It can be rose or orange. There is also, some of my patients, I have them make sure they get anti-reflective coating. There is a reason, a physics law, but the wavelength that cancels out, they actually paint. Anybody can get anti-reflective coating, so you're driving at night, you don't want glare or the sun bothers you. But that can be helpful, anti-reflective coating on your glasses. But colored lenses, typically the orange, the ones that you see the skiers use, or the rose-colored sometimes help too. Yes? I don't have any experience with using those. It's usually in the orange or pink shades. Can anything be done for dorsal midbrain syndrome from brainstem cavernoma after hemorrhage? So, inability to look up, I'm presuming that you're having. It depends what sort of symptoms you're having. Does somebody want to speak up about that? Yes. Yes, yes. And you really have to do, what you have to end up doing is doing head movement. The other thing you can think of, and I'm presuming don't be insulted, wearing bifocals, but you may want to consider not wearing bifocals because, but even bifocals, so when you come to the point of bifocals, you have to look down to read through your bifocals. So we give patients like that what's called single vision readers. So these are my prism reading glasses and these are my prism distance glasses because just the mere fact of going up and down through your bifocal doesn't work either. That's something to think about. But really you have to move your head. There's not a, So, but I would avoid bifocals if at all possible. Use a separate pair for reading, separate pair for distance. And you can even get a third pair. I break the world up into 3 distances: far, computers, and books. You can even get a third pair. But just that you don't have any mixture in your lens. It's just a clean one distance. Can CCM cause a lazy eye? No. No, I shouldn't say that. Say if a child under the age of 10 had an optic nerve lesion, yes. But that's a very specific scenario. And lazy eyes occur, the term is, it's a childhood disease. And just by losing vision in one eye, and then if you regained it, the neglect of it, just like the last lecture, the neglect of that would cause you not to get it back, even though it would have come back in an adult. So it would be a very special circumstance in a child. For patients with CCM, is there value in finding a vision specialist that is experienced with CCM? Well, I don't know of anybody with CCM specifically. For everything from an annual exam checkup to any vision changes and problems. I think, you know, the subspecialty of neuro-ophthalmology encompasses that. I don't think I could see enough patients to maintain a practice if I just did CCM only. So it's not that they don't have a specialty in CCM, they have a specialty in sort of the interface between the neurology and the visual function. And is there any value in seeing an ophthalmologist instead of an optometrist? I work with a lot of optometrists. I think they're very good. I don't know that they're as good with detecting eye movement abnormalities because their training is very different. And as far as the treating, some of them actually do a very good job of treating them, however, as far as the prisms and but of course they don't do the surgery. The real question is if the prisms aren't working, you know, do you have good coordination of care where they have a good relationship with an ophthalmologist? Should surgery be an option? You don't want to be closed out of options because one practitioner doesn't do it. So as long as they have good relationships, I don't think it should be a problem. It may be a slight problem with the diagnosing of something new or, you know, trying to figure out that may be a little bit different. Explain what is going on when you have vision effects as a side effect from anticonvulsants, nystagmus and double vision. It's all those circuits. So I just showed you the nuclei, but there's, you know, nerves running back and forth, and the drugs affect the circuits. There's no question, almost very commonly an anticonvulsant can cause a little bit of nystagmus just to the side, but nothing straight ahead, which is, again, that straight ahead vision is what we care about the most. And it can cause double vision, no question about it. It's also, you can think of it simplistically like alcohol can cause double vision. It's a drug that's affecting your brain. It's not that you're drunk or anything, but these are side effects of the medications, well-known side effects. Any other questions? Or I hope that was helpful. It's very good. Thank you.